So it's been a real pleasure being involved in this series, and I've interacted with a lot of endocrinologists around the world as a consequence of this, who've asked me various questions. So I really appreciate this opportunity and interacting with everyone. So number 10 today, you can see in red are the questions that we've covered so far. Okay, from the very beginning. I think actually the very first one we did was on renal bone disease. And so today we're going to talk about denosumab. And is it okay to stop denosumab? And how should you stop denosumab if you really need to? So a little bit about denosumab. So we've had it for about 10 years. It was approved by the EMA, I think in May 2020. So we've got 10-year data now on it. And as you know, it's a 6-monthly subcutaneous injection. It can reduce your risk of future vertebral fractures by about 68%. So that's from the latest network meta-analysis published in JCM a couple of years ago, and reduces your hip fracture risk by about 39%. So these are real whopping reductions in fracture risk, 68% for future vertebral fractures and 39% for hip fractures. And there in brackets, you can see the equivalent reductions for other medications. So teriparatide is slightly superior, zoledronate slightly inferior, and then you head downwards to alendronate 43%, raloxifene 41%, and HRT that Chana has just been talking to us so excellently about is down to 35%. Okay, and so it's a very potent medication. How much does it cost? Well, you need 2 injections a year, and each injection is going to cost £183 for the actual denosumab, and then you've obviously got the costs of administration. There are some programs available around the country for patients to self-administer, and we did have some patients who did this during the COVID pandemic, and we're trying to seize this opportunity. And there are some GPs who are also willing to prescribe and administer denosumab in their practices as part of a shared care pathway. But it's expensive, £183, which, you know, if you think zoledronate is perhaps 10 to £20 for 5 milligrams currently, if you use 2 smaller vials. So how does denosumab work? So as you can see here, hopefully you can see my mouse. This is the osteoblast, B for blast, builds. Okay, so it's building bone. And here you've got the osteoclast, which is chewing up the bone like Pac-Man. Okay, now the osteoblast secretes these little purple, obviously they're not purple, but in real life, but they're these little purple balls, which are the rank ligand, okay, receptor activator of nuclear factor kappa ligand. And this rank ligand goes and sticks onto rank receptors on the osteoclast precursors and promotes the differentiation, the activity, and the survival of osteoclasts. So you get more chewing up of the bone. Okay. However, denosumab comes along into your bloodstream. It's got a half-life of, I think, about 29 to 30 days, and it will bind to these rank ligands and prevent them from binding to these osteoclast precursors. This is a very similar role to what our endogenous osteoprotein does, which is these green things. But it supplements this. You've got these denosumabs that come in, bind to the rank ligand, so it's a human, a fully humanized monoclonal antibody, binds to this rank ligand and prevents this differentiation and activity and survival of these osteoclasts. You get less bone being eaten up. Okay. So if we go on to the interactive case, it hopefully is on Mentimeter, and I think Chana is kindly activating the Mentimeter. But if we just stay on this slide for a second.
So actually, Alex, I think, I'll do that. I'll do that.
Okay.
Yeah.
So it's a 73-year-old woman. She attends your clinic for review. She's been on 6-monthly denosumab for 2 years. So she's had 4 injections. She's also on calcium vitamin D supplementation. She has no history of fragility fractures. Her DEXA shows that things are improving, So 6% and 3% in the spine and hips respectively, and she's in the osteopenic range at the moment. Now she comes to the endocrine clinic and she's adamant that she wants to stop all these injections to minimize appointments. She doesn't want to come up and down to the hospital, especially during the COVID pandemic. So what would you recommend? So there's option A and B, basically involves stopping the denosumab and giving a treatment holiday, and then reassess everything in a year or 3 years. Option C is to switch to once a year denosumab injections instead of every 6 months. Option D is to switch to zelegenate. So you've given her last denosumab, and then 12 months later, you give her IV zelegenate. And then option E is to switch to weekly oral alendronate, starting at the 6-month post-denosumab, so when she would have had her next dose of denosumab. Okay, great. So just to go through those options, so there's quite a wide choice. I would go with the purple people who would switch to oral alendronate, and I'll tell you why now. If Kareem, so treatment holiday doesn't exist. This concept, it's a bisphosphonate holiday, and it's only for bisphosphonates. Okay, so treatment holiday doesn't exist for denosumab. It's not a good idea. It was a suggested idea maybe 5, 6, 7 years ago, but now we know how reversible denosumab is. This term has been erased, essentially. Okay, so no treatment holidays. So switch to annual denosumab injections also would not be ideal because it's so reversible. You will lose the benefits very rapidly, and you will also enter the risk of multiple vertebral fractures, which can occur from month 7 post-denosumab dose. So this would not be advised. Switching to annual intravenous zelegenate would be an option, but 12 months is a bit late because you will, for reasons I will go through, and my preference would be to switch to oral alendronate starting at 6 months post-denosumab. So the basic concept with denosumab is that it's reversible. So you suppress your bone turnover markers, but they're always starting to come up towards month 6, and then you give them at month 6, you push them down again. Unlike bisphosphonates, where it takes much, much longer for those bone turnover markers to start to rise. Then what you want to do is you want to stop, as they rise, you want to stop them overshooting, which is what tends to happen with delays or cessation of denosumab. The bone turnover markers overshoot, so you have hyperactive bone remodeling, and this is thought to contribute to the excess risk of vertebral fractures, especially multiple vertebral fractures. So you want to get in there as they're starting to rise. Therefore, option D would be too late because at 12 months they've already risen, and I will show you that they're already above the postmenopausal range. So it's too late, and you can have had vertebral fractures even at month 7, month 8 post denosumab. Now, don't forget these bisphosphonates. The way they work is they attach to remodeling bone. So if you give it too early, then it will just wash through and won't stick to your skeleton. And so therefore you need to time it right. For me, I often give oral alendronate because you're getting a dose every week. So as bits of bone start to wake up, as they wake up from their denosumab slumber, then they get given a small dose of alendronate, and that shuts down the bone. Another option is obviously you can give zelegenate, but the bone needs to be as active as possible during the time you give the zelegenate. Otherwise, you probably need to then give another zelegenate, which I'll show you shortly. Okay, so is stopping denosumab okay? So here some data. So this is on the Y axis, bone mineral density % change from baseline. And this is when given denosumab in the top lines versus placebo. And this is for 2 years. Okay, so this is lumbar spine, middle is total hip, and then the other one is the radius. Okay, so you can see for 2 years given denosumab, you're getting around 6% increase in bone mineral density in the spine, around 3.5 in the hip, and even in the radius, you're getting just over 1% improvement compared to placebo, which actually is tending to drop down as expected in a post-menopausal woman. Okay, so denosumab, great gains when you give it every 6 months for 2 years in all 3 sites. And this is reflected in the bone turnover marker. So this is percent change, so 0 is no change, and dropping down means it is being suppressed. So you've got over 80% suppression in CTX, which is the main resorption marker of osteoclast activity. You also get a decrease in P1NP, which is a marker of anabolic activity, the osteoblast activity, but that's because the osteoblast and the osteoclast are coupled, so they communicate with each other, so you tend to see similar direction. But overall, the net effect is that you will stop bone resorption and you may gain a little bit, and that's what's reflected here. Okay, so you've got great, and this is prolonged. This suppression is throughout the 2 years of treatment. Okay, so now we're going to stop the denosumab. Okay, you've had every 6 months, every 6 month domino. Now you put your hand and you're saying you're going to stop. So what happens here? So this is the red line. What's going to happen after this red line? So no more denosumab. And I put here in the yellow box is this dreadful situation where you will lose all the benefits you've gained over those first 2 years within 12 months in the spine, within 12 months in the hip, and within just over 12 months, 12 to 18 months in the radius. Okay, so if you don't give any further denosumab, you will lose all the benefits in 12 to 18 months. You're back to square one. Okay, and you can see even if you delay it by a prolonged amount, if you delay it by 3 months or so, you're losing substantial gains. Okay, you've got this big steep drop off following a delay. Okay, and this is just because the denosumab has washed out. Okay, it's no longer inhibiting the osteoclasts. In fact, what actually happens is all the osteoclast progenitors basically form an orderly queue because they're all paused in their precursor stage by the rank ligand inhibitor by denosumab. Then suddenly the denosumab goes, and this big queue of precursors suddenly goes through the gates, and you get this flood of osteoclastic activity leading to this rapid loss of bone. And that's a mechanism that has been recently identified. Now, if you look at the bone turnover markers, you see this thing that I'm so worried about, this rebound increase in bone turnover markers. Okay, so the placebo, this is what would happen if we gave nothing. This goes along here, the triangle ones. But if you give denosumab, okay, you've got great reduction here, but then if you stop the denosumab without giving anything, it overshoots, okay, beyond the postmenopausal range. And this heightened state of bone remodeling is what brings this very worrying increased risk of fracture straight after denosumab cessation. Okay?
So quick question, how long can you continue the denosumab is the question.
So we've got good data now for 10 years that you can get continued benefits. So it's not like bisphosphonates where you'll see the benefits really in the first few years and then it will plateau and you'll just keep it there. With denosumab, you see continuous gains, at least up to 10 years is the longest data we have at the moment. And it's been around for about 11 years. So hopefully next few years we'll have even more data. But most would continue denosumab beyond 10 years. I mean, we can go into the ins and outs of when you would stop it later, perhaps. Well, I'll tell you now. Basically, what I do is use a sort of treat to target system, whereby once they get down to a T-score of -1.5, there's probably no real benefit in continuing on the denosumab, at which point you then want to lock in the benefits through various maneuvers, which I will go through now. So that would be the best way to approach this. So you take them down to a T-score of -2. The data is -2, but I go down to -1.5 because they will get this sort of, you'll see that none of the ways to stop denosumab works perfectly. So you risk it floating back up to -2.
There's another question. Can I ask another question about What if the patients put on denosumab because bisphosphonates were contraindicated?
Well, then, yeah, very good question. And the answer is then you continue the denosumab. You know, I've got one patient who's on it for about, I think, 12, 13 years before the European license. And so you will just continue. There are some other, you could use raloxifene to take them off it, but they may be too old to start putting them on a selective estrogen receptor modulator, in which case we await further medications and see what we can do. You may try shorter acting bisphosphonates, small trial, depends. It depends.
What agent would you use if a patient gets fractures on denosumab?
Okay, so that's a more general question. It depends if this is truly treatment failure. So I think maybe in Osteoblast 8 or 9 we went through what exactly constitutes treatment failure. Because don't forget, these drugs reduce your risk of fracture, but you can still fracture. Okay, reducing your risk with denosumab by is about 68 to 70%. Okay, but there's still a 30% chance of fracturing essentially. Well, 30% maintained chance of fracturing. So you need to firstly identify that this truly is treatment failure. So you need to also look at things like your DEXA. If the DEXA, the bone density is dropping down, look at how well you're suppressing the bone turnover markers. And then what agent would you use? Well, to be honest, I don't think I can even remember seeing a patient where it hasn't worked, denosumab. I'd probably continue them on denosumab. You may add in teriparatide in some patients. I wouldn't switch straight to teriparatide because that's a bad sequence to do. Teriparatide does not work very well straight after denosumab unless it's added on to the denosumab, which is then continued. And there's also romosozumab, which is just coming out now and going through NICE, which is also an anabolic agent like teriparatide. Okay, so
quite hard to stop them, isn't it? But there's a question: why did this patient start? It's not this patient. Why would one start just for osteopenia with denosumab?
No, so this patient may not have been osteopenic. This is a made-up patient. So this patient may not have been osteopenic to start with, and so they were osteoporotic about 2 years. They're now osteopenic. But the second thing to stress here is that just because someone's osteopenic doesn't mean you don't treat them. You may treat them with quite strong anti-osteoporotic medications. It's all about fracture risk, which you can calculate from FRAX, because they may be osteopenic but on steroids, plus had 4 vertebral fractures previously. Remember, don't be captivated fully by the DEXA scan. Think of the whole picture. It's best to always calculate the FRAX, which will take into account other risks, because don't forget, most fractures occur in the osteopenic population because they are the ones who make up the greatest number of people. Okay. So this is more evidence for why we need to be careful when stopping denosumab. So essentially, these are graphs here of patients. So this is a placebo. So the gray is off treatment and the white is on treatment. Okay. So this is your fracture rate, vertebral fracture rate when you're on placebo, and then when you stop placebo. Okay, so unsurprisingly, there's a real difference. When you're on denosumab, obviously your fracture rate is lower. When you stop the denosumab, it goes up again. Okay, and the same here. This is for patients with prevalent vertebral fractures, and that's without prevalent vertebral fractures. Okay. Here, the problem is, as you can see here, this is the risk of having multiple vertebral fractures, okay? These two ones on the right, these two graphs on the right. And the worry here is that your risk after stopping placebo of multiple vertebral fractures is this. But when you stop denosumab, it's this. This is higher than even stopping placebo. So there's this higher risk of multiple vertebral fractures on stopping denosumab than on stopping placebo. The error bars are quite wide, but if you look at it this way, basically look at this line here, of those who developed multiple vertebral fractures, a greater proportion had stopped denosumab compared to placebo. Okay, so there's this worry that this increased bone turnover, this highly active remodeling that occurs on stopping denosumab, predisposes patients to multiple vertebral fractures. And there's multiple reports of these multiple fractures in the literature. So the message is that when you stop denosumab, you're going to lose the gains within 12 to 18 months at all three sites. So your spine, in your hips, and in your wrist within 12 to 18 months. Very, very rapid, okay? Even a few months delay, you start losing a significant amount. And this is one issue we had during COVID of how to get their patients their denosumab during the COVID pandemic last year. And you've got this high risk of multiple vertebral fractures that starts from around month 7 to 8 after their last denosumab. That's when those bone turnover markers are now over the normal postmenopausal range. So if you're going to stop denosumab, think about an alternative agent, okay? And remember, this is not an issue with bisphosphonates because they have long-lasting protection on cessation because they don't allow this rebound effect because they sit in the bone for many, many years, okay? So this is the denosumab cliff. So those of you who come to clinic with me, you know I talk about the denosumab cliff, and here's a cliff I found in Iceland that nicely demonstrates this. This is increasing bone mineral density. So you give denosumab, your bone mineral density is going up and up and up, and then you stop the denosumab, and your bone mineral density suddenly shoots down. Okay, so this is the denosumab cliff. Okay. So what's the best way to stop denosumab? Well, there's many studies, and I've just put a few of them down here. Sorry, someone's knocking on the door. Hi, sorry about that. Okay, so one of the first one was the Fremantle study that basically transitioned patients from denosumab to alendronate at the 6-month point, so the point when they would have got their next denosumab injection, and there was fairly good stability here in their bone mineral density in the spine, the hips, and the femoral neck. Okay, but other maneuvers have also been tried, especially with zeledronate, and you can see a lot of minus numbers here. Okay, minus 9% when they gave zeledronate at 6 months, minus 5% here. Then more recently, these studies, minus 3%, minus 2%, minus 1.5% over here. And this Solling study, which I'll talk in more detail shortly, where they looked at different timings of these zeledronate, either at 6 months, 9 months, or watching bone turnover markers and watching them go up, but then trying to shut it down with zeledronate. It's also been, this is a reanalysis of the Fremantle study and showed basically fairly good results at alendronate. I'm quite keen on alendronate for the basic reason that this small dose going into the system every week catches the bone as it's waking up post-denosumab, whereas these big slugs of zeledronate, which will last in your system for a day or so and will only get onto the active bone at that moment, may not work quite as well. Okay, so raloxifene's also been tried here as well. This goes back to that question from the audience about switching to raloxifene after you can see there was a drop of 2.7%. So that there are drops with almost all of them. It's a bit disappointing, really, but that's why I would err on the side of continuing denosumab in the first instance, unless you really have to stop it, or their bone mineral density, their T-scores are now around minus 1.5. Okay, so just a bit about this Solling study published in JBMR last year. Okay, so this is a graph, this top left one, of percent change in lumbar spine bone mineral density, 0, and anything going down here is negative, so losing lumbar spine. And so this is patients who had denosumab, and then they were given, in the red line, they were given a Zol here. And you can see still, even though they were given a Zol, there were ongoing losses in the bone. And if they were given, but it's better than if they were given nothing. So nothing was this blue line. Okay, given nothing is what happens if you do nothing. If you don't give anything. If you're given 9 months Zol, so that's basically 3 months after you would have given them their denosumab. It obviously done nothing, so it matches the observation group start with, and then it just tails off. But you can see these are all negative, or all sites. It's basically not doing the job. And then if I just take your attention, look at this right-hand side graph, you can see the change in bone mineral density from baseline to month 12 for the lumbar spine, total hip, and femoral neck. And you can see they're all low. They're all dropped by 2 to 4%. No matter if you do nothing or if you do something. Okay. So the message here is that you will lose bone no matter if you give zoledronate at 6 months, no matter if you give it at 9 months, or if you do it based on rising bone turnover markers. And here you can see a bit of data for the bone turnover markers. You can see if you do nothing, that's this blue group. It goes up here. Once it goes up here, this is where they gave them as a zoledronate dose to bring it down here once it's gone out of range. But you can see with the 6 month and 9 month groups, you're still keeping the bone turnover markers fairly much within this grey region, which is the postmenopausal range. But as I showed on the previous slides, you're still losing bone. So these small rises are enough to cause ongoing bone loss. Okay, so overall, the message is the rebound in bone turnover markers seen post-cessation of denosumab can be suppressed by zoledronate, and then it tends to start to rise, but often within the postmenopausal range. The bone is still lost though. Other findings, so who loses the bone the fastest? It's often those who've been on denosumab for longer, and those who've had very high bone turnover marker baseline, and the younger patients. And there's studies ongoing in this area. Okay, so the message to you today is basically try not to stop denosumab, but if you do need to stop it, use a bisphosphonate. You can use alendronate or zoledronate. Exactly how to do it is the matter of some debate, and I'll just briefly go through these new European guidelines on denosumab that have recently been published. Okay, so essentially, if you're a young patient with a low risk of fracture, it's generally not recommended to be on denosumab. Okay, because we don't know how we're going to stop it. You need to have an exit strategy. Okay, if you've been on it for a short amount of time, so up to 2.5 years, you may be okay to switch to oral bisphosphonates or administer zoledronate, as per the options I went through just now. And then if you've been on for a long time, so you're more at risk of losing the benefits and these multiple vertebral fractures, then tend to continue denosumab at least for 10 years, okay? And in some patients, you may at some point want to switch to zoledronate. And the basic protocol, assuming you haven't got bone turnover markers, is to give a dose at 6 months and 12 months. So normally zoledronate is given every year, but here you're going to give, so denosumab will be 6 months, 6 months, 6 months, and zoledronate 6 months later, and then another one 6 months after that. And that will catch all the bone as it's waking up as much as possible. The other alternative is to just start them on alendronate from the 6 month onwards. Okay, so those are the current ways to stop denosumab. And my point here is basically have a good think before you start a patient on denosumab. I've been referred a lot of patients who in the private sector have been started on denosumab with no thought to the exit strategy, which causes a lot of problems thereafter. Okay, so think, might they miss their injections? Because remember, you need to have your injection every 6 to 7 months. Any longer than that, and you're starting to lose bone rapidly and enter this enhanced vertebral fracture risk period, okay? So if they're very frail, you think they may not be able to make it to their hospital or to their GP for the 6 monthly injections, think twice, okay? Think twice what their prognosis is in general for their life expectancy. Think also, are they going to be able to get up to the hospital without any delays, for example, during the COVID pandemic? If so, if you're worried about it, have a think. Should maybe a bisphosphonate may be better, maybe raloxifene may be better. But often, you don't want to do more harm than good. So really have a good think before you start denosumab. It's a great drug. You'll see excellent. You'll see up to 20% increases in lumbar spine density at the 10-year point. It reduces your fracture risk dramatically. So I think it is a great drug, but you need to think before you start it and think about before you stop it, essentially. Okay, so that concludes part 10, and thank you very much for listening.
Thank you, Alex. That was great. I can see Chana's already put a question up. Do you want? There's a few questions in the chat that you can see. Do you want to just type answer? There's one about what you do in a patient with osteoblast of the jaw that was caused, we believe, by the bisphosphonate. And now he's better. Can he start denosumab, or is the risk just as bad?
Well, the risk is still going to be there. Maybe it might be a bit higher with denosumab because you've got that higher amount of bone suppression. However, the benefit is that denosumab is short-lasting, so you could try it and see if they can tolerate it. Personally, in these sort of situations, I may try something like Residuant, which is a shorter acting bisphosphonate, and see if they start to tolerate that. Or if you can, try and get an anabolic instead, like teriparatide, depending if they meet the NICE criteria.